Moving on to respirations now. Let me just turn off this other one. Okay, so first things first, what is the main thing we are worried about when it comes to the respiratory system? The primary homeostatic variable is our O2. Are we getting enough oxygen in the system? That's the role of the lungs. We can exhale CO2, but the main job is keeping that PaO2 stable. The rate of O2 uptake in the lungs and CO2 excretion must match the rates of still getting used to all these sensitivities here. O2 use and CO2 production. So whatever you create or use, we have to match whatever we supply and get rid of. Main components, lungs, chest wall, and our pulmonary blood vessels. We have chemoreceptors, and their job is to sense what the concentrations of our oxygen and CO2 are. So we have to talk about ventilation, gas flow, diffusion of gases, and perfusion, blood flow. It's great that our lungs can oxygenate and they can get air in. But if there's no blood in that area, all that O2 is just wasted because it's not getting into the blood. There's no perfusion. So we're talking about perfusion is dealing with blood. Always understand that when it comes to the lungs and any real part of the body. Perfusion is blood perfusing that tissue. Our blood-gas interface, obviously we have a very, very large surface area due to all these alveoli. They all have small capillaries that surround each alveoli, so we have plenty of surface area for all the gas exchange to occur. Ventilation, we're going to talk about ventilation. So ventilation, when it comes to the lungs, we call it VE, which means minute ventilation. It's a flow. How much air? We're just talking about air when it comes to ventilation. How much air are we able to move in and out every minute? So the units are liters per minute. What also do we learn about in the cardiovascular section that is also reported in liters per minute? Cardiac output. What is the formula for cardiac output? Heart rate. So you have a rate of something, and we have a volume of something. With ventilation, it's the same thing. We have tidal volume, which is just the amount of air you breathe in and out every beat or every breath. How much air are you moving? Multiplied by your respiration rate. I'll put R. Respiration rate. How many times a minute do you breathe? Multiply them together, and that tells you your minute ventilation. How much air can you move in and out of your lungs each minute? Just like cardiac output. How much blood can your heart pump each minute? Okay? Also, all these membranes, the blood-gas interface, less than 1 micrometer thick, and it has 4 elements. So this is the order that oxygen, for example, has to go through to get into the blood. Thin layer of surface liquid, what's that called? What's the little liquid in the alveoli? Surfactant. So we have surfactant. Our alveolar lining. Then we have a very thin layer of interstitial fluid. And then finally we have our pulmonary capillaries. When you get to start learning about diseases, we're talking about diffusion time. Remember, diffusion has to be across a distance. The thicker the distance of diffusion, the slower it's going to be. People have like chronic bronchitis. All this mucus is lining everything. You're increasing the diffusion distance, and they have problems with breathing O2. So again, anything that increases any one of these things is going to increase diffusion time and cause a problem with O2 delivery to the tissues or getting into the blood. Okay, so all gas occurs via diffusion. It's gas exchange, they go right through. O2 concentration is higher in the lungs than in the blood, so therefore O2 will go into the blood, and that's the way we want it to go. CO2 concentration is higher in the blood because we're producing CO2 as a byproduct of our metabolism, and that excess CO2 diffuses into the alveoli, and then we exhale it out. So that's O2 and CO2. So we have some laws we have to follow when it comes to gas. Gas behaves differently than blood does because blood is a fluid. Air is not. It's a gas, so it can be compressed without changes in volume and pressure. So Boyle's law, and again, you're not going to be required, on your exam, I'm not going to say, like, what's Boyle's law? But to understand these makes sense why we have the concentrations we do in our body. So the first thing has to do with Boyle's law. This is just airflow into the lungs with inspiration. So the pressure of the gas is inversely proportional to the volume. So when it comes to air, increase volume, decrease in pressure. So think about it. We have to get air from the outside environment into your lungs. If the pressure built up whenever you took a breath in, you'd never be able to get more air in because the diffusion gradient is favoring to go out. So by breathing in, big volume of air in, the pressure keeps dropping, allowing more air to get into your lungs. If it was the opposite, like it is with blood, if I increase the volume, I'm increasing the pressure, I can't get any air in because the pressure gradients are off. So what Boyle's law tells us, we can breathe in deep, and our inspiration, remember, intrathoracic pressure drops because of the volume of air in our lungs. Pressure drops, allows air to go in. So that's all Boyle's law is telling us. So it behaves differently. So when you increase the volume of air, the pressure inside the lung tissue itself goes down. Now, lung volume is first increased when inspiratory muscles expand. So as soon as you take that first little bit of a breath, you can feel a little bit of resistance, but after that, you can breathe in really easily. But that first little bit, you have to overcome those little intercostal muscles, your inspiratory muscles. So you have to get, obviously, air in, and then your pressure drops, and the rest of it goes in. So breathing is passive. We can control our breathing through voluntary muscle, but for the most part, you're all listening to me, you're not thinking about breathing, you're just breathing on its own. And all it is, when you breathe in, air goes in because of pressure, and then exhalation is just passive with your normal chest recoil. Our chest expands, but it wants to snap back. So expiration at rest is passive, and we'll get to what happens later on with exercise. So that's Boyle's law. Dalton's law just states that each gas that's in the air right now has a pressure associated with it. So if you basically add up all the gases in the air, we have CO2, O2, nitrogen is a lot of, whatever else is out there, they all have a percentage. What's the percentage of air that's oxygen? About 21% of the air is oxygen. How much is CO2? It's like 3%. And there's a lot of nitrogen in there and whatnot. But that means that whatever pressure, 21%, what's a normal barometric pressure, like 1 bar? What's the millimeters of mercury that we look at? 760 is a normal atmospheric pressure. That's 1 bar. So 760 times 20%, 21%, that tells you how much pressure that oxygen is exerting in the air. Then Henry's law just states that whatever gas is dissolved in liquid is proportional to its partial pressure. So whatever you're breathing in the air is what's going to get inside you. That's why when you go to high altitude, people have problems breathing because the O2 is less in altitude. So because it's less in altitude, people have problems breathing because there's less oxygen in the air. So whatever's in the air is what goes into our bloodstream, and they're all related. Now, we have to talk about water vapor. Okay, if you go breathe out hot, your hand gets wet We have water vapor in our lungs to moisturize the air. No matter how cold it is outside, by the time the air reaches your alveoli, it's up to normal body temperature. It's been humidified and heated up as it gets through the lungs. No matter how cold it is, you feel the burning right in your bronchus in those main areas. But once it gets to the alveoli, those the further down, it's up to room temperature. So the reason why we have to talk about water vapor is because, yes, we have a certain pressure of oxygen in the air, but when we breathe in, we're adding in water pressure and water vapor. You have to lose something from somewhere else. It's like a big pizza pie. If you're taking it from one, you got to lose to the other. So when we get to the actual what is in your blood, it's a little bit less than the environment because we're adding in water vapor. So you'll see the numbers are going to change when we get to the actual blood O2 concentrations because we have to add in water vapor. So let's talk about how we breathe. Okay, so getting air in and out of the lungs is all based off of pressure gradients, high to low. We all go from high to low pressure. So when we breathe in, the pressure drops, getting lower in our lungs, so air can get into our lungs. Breathing will become difficult if the chest wall becomes stiff. Here's our compliance again. We have to breathe in. If our chest wall is very stiff, you can't expand. It's like put your hands around your arms and try and breathe in deep. You can't do it. It's like wearing a straitjacket. It's a restrictive disease. Resistance is high. Resistance, when we talk about resistance, it's resistance to flow. What's in the way? Compliance is dealing with the elasticity of the lungs. Okay, the lungs have elastic properties as well. Emphysema is a disease that destroys the elastic properties of these lungs, and you start losing blood volume, air volume, lung volume because of the emphysema. So resistance is a dynamic property, happens during flow. Are we resisting your flow to air, making it harder to breathe? Asthma, bronchitis, those obstructive diseases. And then compliance is elasticity of the lungs. So we have to talk about lung volumes. We're going to draw it out. So all these are just definitions, and we'll talk about these as we draw out our lung volumes on this curve. So the first thing we're going to talk about is our tidal volume. This is just the air that we breathe in and out with every beat. Okay, so we'll start right here. And our tidal volume okay, TV for tidal volume. So that's just you all right now, you're breathing in and out, nice and relaxed. This is your tidal volume, in and then out. And then in and then out. That's just your normal tidal volume. Now, I'm going to tell you, okay, do a normal breath. Now I want you to breathe in as much as you can, all the way in. So we're going to breathe. We're going to go all the way up. Breathe in all the way in. So you can't breathe in anymore. And then we'll come back down to our normal tidal volume again. Okay? This segment is called our inspiratory capacity, or inspiratory, I'll put inspiratory reserve volume. I'm sorry, let me put that instead. Inspiratory reserve volume. How much air can I breathe in above your normal tidal volume? How much air do you have in your lungs? All the way in, it goes all the way up. Now we're going to say, you go back to your normal tidal breathing. Change the color. Now I'm going to tell you to exhale all the air you can out of your lungs. Okay, so now we're going to breathe out and back up again. And this is known as your expiratory reserve volume. How much air is left in the lungs, or how much air can you get out of your lungs for exhalation? So this is your expiratory reserve volume. Then the last thing we're going to have them do is we're going to breathe in all the way in and then all the way back out again. So after a tidal breath, we're going to go all the way up, in, and then all the way back out again, and then back to normal tidal volume. This segment, the red, is called our vital capacity. What does vital mean? Life. Okay, this is the amount of air we can breathe in and out of our lungs at max capacity, all the way in, all the way out. This is the total amount of air that we have for exchange. We do have a little bit of residual volume left in our lungs, and it's called residual volume. There's just a little bit left that we can't get out, and that's called residual volume. It's just whatever's left in the lungs so they don't collapse on themselves. Remember, we don't want our lungs to collapse. Once they collapse, it's hard to get them unstuck. So by having a little bit of air left in the lungs, it keeps those alveoli propped open enough. That surfactant helps keep them open as well so they don't collapse, and then you can breathe again. So volumes are always one unit by itself. So tidal volume, inspiratory reserve volume. So what we do is we start adding them together. So we get inspiratory capacity. How much can we inspire? Which is the tidal volume plus your inspiratory reserve volume. That's our inspiratory capacity. How much air can we breathe in total? Okay. We have expiratory capacity, tidal volume, plus expiratory reserve volume. That's another capacity. All these are on the previous slide. They're all the same. In that table, it's the same thing. Okay. We also have, let's see, make sure I'm right. We have TLC, not the group, total lung capacity, and that is IC plus EC plus your residual volume gets added in here now. Okay, this gets everything. So basically, well, plus your tidal volume. So basically all three of these things is your vital capacity. So TLC, vital capacity, plus your residual volume. That's pretty much all the lung volumes added up together, is your total lung capacity. Okay, it includes all the air, your vital capacity, all the way in, all the way back out. But remember, there's still a little bit of volume of air left in the lung. That's your residual volume. Residual volume plus vital capacity equals your total lung capacity. So capacities are always two volumes added together. The volumes are just the plain volumes by themselves. Okay? There will be one question on your exam explaining what is the residual volume or what makes up vital capacity. And I'll say these are the things that make up vital capacity. Which one's the right one? That'll be a type of example of a question based off of this graph. Any questions about lungs and how we breathe in and out? This is just normal breathing. Anyone here ever do these pulmonary function tests due to asthma? Okay, so you should know this one. This last unit we talk about with breathing is called forced expiratory volume test, or FEV1. What we're testing for here is how much of your total lung capacity that you have in your lungs, how much of that can you get out of your lungs in 1 second? So it's a forceful inhalation, forceful all the way out. Very, very fast and forceful, get all that air out as much as you can. We want to see how you do in 1 second. How much can you get out? Graphs look like this. You breathe in, and then out. And we see in 1 second how much of that air came out. What does that tell us? Obstructive diseases, okay, COPD, asthma, they have obstructions to flow. Will they be able to get out a lot of air in 1 second? No. So those patients with like COPD, FEV1 goes down. Now, what is the other type of lung diseases? You have obstructive diseases and you have, what's the other one? Restrictive diseases. Restrictive diseases have no problems with flow. Their problem is volume. They just can't get a lot of volume of air in. But they can move it very easily. Think about having a straitjacket on you. Try and take a big breath in with a straitjacket. You can't do it. It's a restrictive disease. It's restricting the volume, but I can still get the flow out fast. Just giving you real world examples of why we know and look at this number. So FEV1, just know how much air can I get out in 1 second. That's all you got to know about FEV1 for now. And then we just talk about that. Muscles of ventilation. Obviously, our diaphragm is the big one when it comes to inspiration. The external intercostal muscles create this bucket handle right here, so it allows your lungs to expand like this. That's why PAs, when you do that diaphragm, thoracic expansion, you put your hands on the side of the ribs, and they breathe, and you see the rib go like this. Your hands should move like that. That's what's going on there. Expiration is passive at rest, but active with exercise. You have to be actively exhaling during exercise. Okay, so what happens when you start running for people who don't run very much? What do you get? You get side splints, right? Little pains in your sides. Why? Because those muscles are being used probably for the first time in a very long time, because you don't exercise. Then when you start exercising and doing it, you start getting pain here because those muscles are fatiguing out. Because now with exercise, expiration is active. We actively have to squeeze our abdominals, abdominal wall, those intercostal muscles to exhale during exercise. If you eat ribs, it's those little rib meat in between the ribs. That's what you're eating, are those muscles that help you with breathing. So when I taught high school, and so we did all the muscles and everything, so we brought chicken wings in. We told them to like identify like what are the muscles? So anyway, so your internal intercostal muscles are right angles to your external obliques, and that assists with the exhalation that occurs during exercise. Airway anatomy, we have two major zones. The conduction zone just conducts air. They're just tubes. There's no diffusion happening. These are your trachea, bronchus, the right and left bronchi, and the bronchioles. And then finally we get to the respiratory zone. And this is where the gas exchange starts to happen. Okay, we have a thing called a lung acinus, which is just a functional unit formed by the terminal bronchioles, alveolar ducts. Basically, that's what it is. So an acinus is like one little stalk of broccoli with all the little alveoli on the end. That's an acinus. It's just a functional unit. That's all. Elasticity. So remember, we talked about recoil. When we breathe in, our chest wall expands, but the natural properties of our chest wall are to recoil. And again, that's why breathing is passive at rest with expiration. It's just your normal chest wall collapsing on itself. So they're always under elastic tension because they're attached to the thoracic wall. So the lungs, the outer layer, the visceral layer of the lungs, are attached to the chest wall. When you get a pneumothorax and the lung collapses, it pulls away from that chest wall, and you lose that suction. So what you have to do is you have to do a chest tube to pull the air out that got into that lung cavity. Sometimes they'll put like talcum powder, like baby powder, on the lung, and it helps it attach back to the wall. So that's what's going on there. Again, tension increases during inspiration, and then passively recoil, and that lets air out. And obviously this tension is reduced by elastic recoil during exercise and expiration, and that allows us to get back to our normal setting. The law of Laplace we talked about, not really, it's going along with like Boyle's law, that the pressure is inversely proportional to the radius of the alveolus. As the alveoli gets bigger, the pressure goes down. Again, we need air to travel. It goes from high to low pressure. We have to create these low pressure environments. All we're saying here is that small alveoli would be at risk of collapse without surfactant. So as those alveoli start getting smaller and smaller, remember we need to have a little bit of air left in there to keep them open. The surfactant helps as well, keeping that surface tension there so that the alveoli won't collapse on themselves. We don't want them to collapse. Here's just another one, talk about surfactant, secreted by type 2 alveolar cells, hydrophobic proteins, so that water-loving or water-hating, so it's going to resist water, push it away, reduces surface tension between water molecules, prevents collapse is the big one, and again, allows residual volume to remain in the lungs. That's the role of surfactant. Just a quick clinical correlation regarding surfactant, this respiratory distress syndrome of the newborn, called hyaline membrane disease, usually associated with premature babies when they're born without surfactant, because the lungs are the very last thing to develop in babies. The entire time they're developing, the mother provides all the oxygen for them. So they don't need the lungs. So the lungs are the last thing to develop. So when preemies are born, they usually give them some steroids to get that surfactant being made so that they can breathe and not have any respiratory problems. So that's kind of where this is going from. Don't go crazy. Okay. Regulation of breathing. How do we regulate our breathing? This is a vital process, so of course it's going to happen in the brainstem, your medulla oblongata. Heart rate control is there. Breathing control is there as well. So breathing comes from motor neurons from 2 different areas of the brain. Why 2 different areas for breathing? What's special about breathing? What can we do with it? We can control it. So we have voluntary and involuntary inputs into our lungs so that you can breathe at night when you're sleeping and you don't need to think about it. Obviously, we have the voluntary breathing, motor control from the cerebral cortex. Remember, the cortex is where all the motor function comes from. Okay. And our involuntary breathing comes from the respiratory control centers in our medulla oblongata and the pons. So respiratory control centers are there for our normal day-to-day involuntary breathing. So here is our voluntary coming from the cortex. We get input from other receptors. Because remember, if you ever had an anxiety attack and you start breathing heavy, that is the input coming from these areas saying we're having an attack. Start breathing heavy. It's induced from those other places to control your breathing and make you breathe heavier. We have stretch receptors. Okay, they're going to want to know how big the lungs are being stretched. If it gets too much, we can reduce our breathing so we don't, exhaust our inspiratory muscles out and so forth. We have irritant receptors. Okay, if you ever cough on water, we go down the wrong tube. That's your irritant receptors that are being triggered to make you cough, to get stuff out. We also have our peripheral chemoreceptors. Carotid body, aortic arch. They're looking at O2 levels, CO2, and H, hydrogen, the pH of the blood. That will tell us a lot of information, what's going on with your breathing, metabolic requirements when we start seeing changes in your pH. We have central chemoreceptors, again, CO2 and hydrogen. And we have receptors in our muscles and our joints. When you start exercising, the fact that you're moving your muscles and doing things will make your breathing rate go up. Because we have a greater demand of oxygen because we're exercising, we're doing some activity. We have to get more oxygen in. We need to breathe more to get more air in, more oxygen available for diffusion. So these peripheral and central chemoreceptors are the same ones that we talked about, the baroreceptors for the cardiovascular system. They follow the same nerves, so make sure you know which nerve controls what or senses what when you're studying, because it's the same one. So brainstem receptors, motor neurons. The major nerve is our phrenic nerve. C3 to C5 is the phrenic nerve, and that goes right to our diaphragm, and that helps control diaphragmatic muscle. Other ones that are going to help rise from the thoracolumbar region of the spinal cord to go to the lungs as well. Obviously, we have the blue, which is parasympathetic innervation. Red is your sympathetic. We know because of that sympathetic side chain ganglion that's right there. And we have our motor, which is all the green, arising from C3 through C5 to make that phrenic nerve. Pons, obviously, is going to influence our medullary activity, has an apneustic center, promotes inspiration, and a pneumotaxic center, which inhibits respiration. So sometimes you'll have buildup of CO2. We have to get rid of it, so we need to induce hyperventilation to get rid of that CO2. That's a response in the apneustic center to blow off that excess CO2. If we have too low CO2 through hyperventilation, we try and get that pneumotaxic center involved to inhibit your breathing, to slow your breathing down. So just know apneustic, if I'm going to stimulate the apneustic center, I'm going to stimulate breathing. If I stimulate the pneumotaxic center, I'm going to inhibit your breathing. And then here are the centers. We have our pneumotaxic center, apneustic. Now, what was the apneustic area? Is that going to stimulate or inhibit breathing? Stimulate. The pneumotaxic center, what's that going to do? Inhibit. Now, remember what we learned about our neurons and the way the neurons get the impulses from the preceding neurons through dendrites acting on that soma in the cell body. Remember where the inhibitory ones were? Right towards the end, right before you went to the main part of the neuron where you send the signal. Look where the inhibitory ones are here. It's going to block any stimulatory if you stimulate the pneumotaxic center. It's closer up. It's going to have an inhibitory effect and stop any apneustic stimulation in its tracks. So again, we have the inhibitory one right at the end so we can block any stimulation to provide that negative feedback. Again, here are the chemoreceptors. Okay, they can control breathing based off the feedback from our chemoreceptors. They're going to monitor pH of the blood. And then here's your answers for the one I told you before. Your carotid body, cranial nerve 9, the aortic arch is your vagus nerve. So make sure you understand what type of pressures they're looking for, because they have baroreceptors there. They're high pressure, low pressure when you're doing the cardiac. But in the pulmonary, they're also monitoring blood O2 levels, CO2 levels, and pH as well. So Regulation of ventilation, we have the cerebral cortex is involved. Here's our pons with our apneustic and our pneumotaxic centers. They're going to have an influence on the medulla oblongata, which then will regulate your breathing to the spinal cord through its PNS, SNS inputs, or if it's voluntary breathing, still goes to the spinal cord and then obviously through your phrenic nerve to get you breathing more. So this is a graphical way of just looking at how our breathing is regulated. Okay, we'll do this and we'll stop for a break. So effects of pH and CO2 on ventilation. In hypoventilation, is that fast breathing or slow breathing? Slow breathing. CO2 levels rise. They're going to go up. We're not breathing enough. Hypoventilation, because we're not having a lot of breathing, we're not having a lot of gas exchange, CO2 will start building up in our blood because we're not breathing enough to exhale it. So if CO2 level goes up, is CO2 an acid or a base? Acid. So our pH levels start to fall. We become more acidic. So hypoventilation causes a respiratory acidosis. The respiration is causing the acidity by not breathing enough. In hyperventilation, now we're breathing too much. CO2 levels fall because we're breathing a lot of gas exchange. CO2 goes off really fast, and our CO2 levels drop, called hypocapnia, and the pH levels rise because we're losing CO2, we're losing the acidity. Our pH levels will start to rise. Ventilation is controlled to maintain constant CO2 and a blood pH between 7.35 and 7.45. Increased CO2 is the primary drive for breathing. CO2 is what does it, not lack of oxygen. So let's take this step by step. First block, emotional and voluntary control. Okay, anxiety attacks, scared. Okay, these go to your limbic system, higher brain centers. We look at the scenario, we compare it to what we've had experience in the past. Is this a scary environment? Yes. Induce anxiety. Goes through all these systems. Medulla oblongata and pons. We increase our breathing, and we have an anxiety attack. So that's one way we can alter our breathing through emotions. How does CO2 by itself have an issue? CO2 is sensed by our medullary chemoreceptors and the carotid and aortic chemoreceptors. So this one is central. These are your peripheral. CO2 is sensed 3 different areas. 3 areas are sensing CO2. Again, CO2 is the main driving force for your breathing. So by having a lot of sensors for it, makes sense. It helps us out. Then it's going to have whatever effect it needs to do. O2 and pH are just sensed by your carotid and aortic chemoreceptors. So that's where the difference comes in. O2 and pH are just peripheral, affect your afferent sensory neurons going into the brain, and then has its effect downstream. Somatic motor neurons for expiration, your internal intercostals, and your abdominal muscles. That's how we expire. Those are the 2 muscles involved for that. If we're going to deal with inspiration, diaphragm, your external intercostals, and then your scalene, sternocleidomastoid muscles, those are your accessory muscles to breathing. If you see a patient and they're in a really bad asthma attack, and you see them breathing like crazy, and you can see all their SCM sticking out, the scalene muscles sticking out of their neck, that means they're really trying to get air into their lungs. They're using all their muscles to really get the air in because they have such obstruction. They have to generate a lot of force to get the air in. They have to breathe in really hard. The problem is they're going to fatigue out fast. They can't keep that inspiration going for a while. And when they can't hold it anymore, they can't breathe as much anymore, CO2 starts to build up, they hypercapnic, and they start causing other problems from there. That's why CO2 is so bad. So, again, understand that with regards to O2, CO2, pH, and where they are sensed. Okay, so here's effect of PCO2 on ventilation. Again, with hypoventilation, we're not breathing very much. Arterial PCO2 is very high. Normal ventilation, we're right around 40. And then with hyperventilation, we're blowing off all the CO2. CO2 drops down to there. So you can see how these changes in CO2 occur just by changing your breathing patterns. Chemoreceptor control. Now we're dealing with our CO2 here. Okay. So we have a decreased ventilation as the stimulus. We're not breathing enough. We have an increased arterial PCO2. CO2 is starting to build up in our system because we're not breathing enough. That's going to cause your blood pH to drop. That's being sensed by your peripheral chemoreceptors. Remember, pH and O2 are only peripheral. CO2 is central and peripheral. And these sensory neurons go to your respiratory center in your medulla oblongata, obviously to increase your ventilation. The plasma CO2 also by itself can get to the brain, causing decreased pH of the interstitial fluid within the brain, activating your central chemoreceptors in your medulla oblongata. Again, we need to increase our respirations to drop our CO2. So these are the responses that our body takes in response to decreased ventilation. Okay, remember, CO2 is the main drive for breathing. The effect of oxygen on ventilation. O2 levels will indirectly affect ventilation by making sensitivity to CO2 greater. So if your O2 levels start to drop, the O2 dropping makes your receptors to carbon dioxide more sensitive, so it has a greater response. So the O2 drops, just makes carotid bodies more sensitive to carbon dioxide. It's also called the hypoxic drive. The carotid bodies will respond directly to low O2 dissolved in the plasma below 70. So below 70 is you get to that hypoxic drive, you knock out your O2, your CO2 becomes more sensitive to receptors, increasing your breathing. And then here's just a summary slide of what happens. So we'll take a break, come back at 1:30, talk about blood flow. Okay, let's get started. So we talked about how air gets into our lungs. We talked about the effect of CO2, O2, and pH on our lungs, what happens. Let's talk about pulmonary blood flow, because obviously blood has to get through the system to be perfused so we can get O2, we can deliver CO2, and so forth. So because we're dealing with the pulmonary system, we're going to be dealing with the right side of the heart now. Right ventricle pumps to the pulmonary system. So any changes that go on with the pulmonary system are going to be reflected in the right ventricle. The mean pulmonary, so again, make sure you really read the words because they're going to start combining similar topics. And make sure you understand that we're talking about pulmonary artery pressure. So your MAP for the pulmonary system is about 10, and your systolic is about 25, and your diastolic is about 8. Very, very, very low pressures on the right side of the heart. The left atrial pressure is about 5 millimeters of mercury. And again, that provides the gradient. Because remember, for the pulmonary system, it's the right ventricle pressure that we generate. And what chamber of the heart does it feed into? Left atrial. That's the gradient to allow blood to flow through the pulmonary system. As long as that gradient is still there, we're okay. Blood will flow through the pulmonary system. Why it's nice? Okay, so let's continue on. For the systemic circulation, left ventricle pressure, and where do we have to wind up? Right atrial. And that's the pressure gradient for the systemic circulation. Okay, whatever the ventricle is to the right atrium. Lower BP in our pulmonary system reduces workload on the right ventricle and reduces risk of excessive interstitial fluid formation, which will obviously, anytime you see excess interstitial fluid formation, remember, that's one of those layers you have to go through for diffusion. And if we're increasing the interstitial fluid formation, we'll interfere with our O2 diffusion because we have a thicker layer to get through. Cor pulmonale is one of the only times you'll see right-sided failure by itself. The main cause for right-sided heart failure is left-sided heart failure, but there are causes sometimes where the right side will fail by itself, and it's usually due to specific problems with the lungs itself, a clot in the lungs, scleroderma, which is vascular disease, and COPD. These are things that, again, don't worry, it's not going to be on your test. We're just reinforcing that things that affect the lungs by themselves have an effect on the right ventricle itself. Okay, we're talking about pulmonary vascular resistance, not systemic vascular resistance. If I increase systemic vascular resistance, that's on the body and the left side of the heart. We're talking about pulmonary vascular resistance. What's the resistance through the pulmonary vasculature, and how does it have an effect on our breathing? So low perfusion pressure drives pulmonary flow because pulmonary vascular resistance is low. Everything flows really easily. Resistance is shared between arterioles, capillaries, and venules. We have alveolar vessels that are influenced by alveolar pressure. When we talk about the alveolar pressure, it's the pressure inside the alveolus due to air that's in there or may not be in there at that time. Our extra alveolar vessels, these are the ones, remember we had that picture way before, we had the alveoli, and then you had, remember we had all the capillaries were right around the alveoli. That's what we're talking about, these extra alveolar vessels. As the lung expands, the radial forces increase and causes these extra alveolar vessels to open, which reduces resistance. So remember, as the lungs expand, the radial forces that push out, and it just pops these vessels open, allowing for capillary blood flow. If we have capillary blood flow and we have ventilation in the alveoli, we're going to have gas exchange. You have to have both things there, ventilation and perfusion. Those of you who worked in the hospital, if you did anything with nuclear stuff, have you ever seen what's called a VQ scan? V is what? Ventilation. What's the Q? Perfusion, cardiac output. We do see if there's a mismatch there. To see if there's a clot in your lungs, if you have a PE, pulmonary embolism. It means we have a mismatch somewhere, you don't have to know it again. It's just putting stuff information, if you've heard it before, now you know what it means. Where's the rest of this stuff? Oh, let me just close this out and I'll reopen it. Okay. So, look at this graph. Pulmonary vascular resistance. Pulmonary circulation is forced to accommodate large increases in blood flow when cardiac output increases. Exercise. We need more blood going into the lungs so that we can perfuse it and get more oxygen into the system. So as cardiac output increases, pulmonary vascular resistance decreases. Why is that important? What's going to happen to flow if the resistance decreases? Increases. Why is increasing flow of blood very important for exercise? We need more oxygen in the system. We got to breathe heavier. Yeah, we can breathe heavier, but if we don't increase the amount of blood going into the lungs, it's not going to matter. They have to be the same. So we have this match of ventilation with perfusion so we can get our blood oxygenated. So here's our pulmonary vascular resistance. Here's arterial blood pressure. During exercise, because pulmonary vascular resistance occurs because of distension of the pulmonary capillaries and recruitment of capillaries. So those extra alveolar capillaries that surround each alveoli, the diameter is going to increase. If the diameter increases of a capillary, what happens to the volume that can get through it? Increases. So we have more. The other thing we do too is recruitment of pulmonary capillaries. Right now we are all at rest. We're all upright. Most of your blood is pooling in the base of your lungs. So the 2/3, the zone 1 or the numbers, but the top 2 zones of your lungs right now have the ability to be perfused, but you don't need it because you're not exercising. There's no demand for oxygen, so they just stay ventilated. You breathe in and out, you can hear it on the lungs, but they're not being perfused. We don't need it. When we need it, blood pressure starts going up. We're exercising. We need more oxygen going through. We need to breathe deeper and heavier. As we start doing that, blood starts to fill up all those remaining parts of the lungs. Now we have a reservoir of O2 waiting there. When we need it, we recruit more capillaries, incorporate more parts of our lungs. They're all being perfused. They're all getting oxygenated. Therefore, our tissues will get oxygenated as well. This is talking about lung volumes and pulmonary vascular resistance. At low lung volumes, like a restrictive disease will compress your extraalveolar vessels, leading to an increased resistance. So, low volumes, restrictive lung diseases. These are your lung volumes. These are the low side. We get compression of the vessels. When you compress them, the radius decreases, right? If the radius decreases, what happens to the resistance? Increases. So at low lung volumes, all those extraalveolar vessels all collapse. They don't stay open. Remember, the opposite we learned before. When the alveoli increase and they get big, what happens to those extraalveolar vessels? They get big as well. But now there's low lung volumes. Those alveoli get very small. They start to collapse. When they collapse, the extraalveolar vessels collapse as well. If you're losing surface area, resistance goes up. Now, at very high volumes, like emphysema, your pulmonary capillaries get stretched. When you stretch something, what happens to the width of that object? It decreases. We have very high lung volumes now. So all the alveoli are not their normal popped open, now they're bigger. And when they get really big, all those little capillaries that travel around them, they get stretched. When they get stretched, resistance goes up. And that's why up here we have these two sides of the story. We want to operate right there. That's a great normal lung volumes. We're right in that sweet spot of pulmonary vascular resistance. When you start adding in pathologies and different problems, you get changes in pulmonary vascular resistance on the low side and the high side. So when you're studying this, understand why at low lung volumes does PVR go up, and why at high lung volumes does PVR go up as well. Pulmonary vascular resistance, not anything else. So smoking destroys the alveolar membrane and your corresponding capillaries with smoking. So we're going to decrease pulmonary capillary cross-sectional area because we're losing capillaries, and they get an increase in pulmonary vascular pressure. That's why smoking is so bad. So it destroys your lung tissue, causing less capillaries. Less capillaries is less cross-sectional area. Resistance goes up. Regional differences in perfusion, like I said before, blood flow is greater at the base of the lungs than at the apex. Again, due to gravity, blood's just going to sit in the base of your lungs. Nothing wrong with that. And because of that, we get 3 lung zones that are created within this gradient. So here are the lung zones. Zone 1 in blue. Let me change my color to blue so we're all the same. Zone 1 is over here. Zone 1, if you look, is at the apex. It's 1, 2, 3. So 3 is the base, 1's the apex. In zone 1, arterial and venous pressures are both less than the alveolar pressure. So here, the big A is arterial, big V is venous pressure, the little a is alveolar pressure. Alveolar pressure is right in the middle of these two. Remember, we're at the apex now. We get compression of pulmonary capillaries, no perfusion. So in this case, in zone 1, you can see here, we're clamped off. Alveolar pressure isn't great enough. So zone 1, it's ventilated but no perfusion. It's called alveolar dead space. Ventilated but not perfused. Zone 2. In zone 2 is the green, is the middle of our lungs. Alveolar pressure is between arterial and venous pressure. You can see here, little a is greater than arterial and venous. This is the middle of our lung. Vessels are partially constricted. Blood flow is limited in zone 2. Zone 3 is at the base. Zone 3. Increased hydrostatic pressure of blood. Why? Why does hydrostatic pressure go up in the base, zone 3? That's where all the blood is. More blood volume, more hydrostatic pressure. It goes up. In this case, arterial and venous pressure both exceed the alveolar pressure, and therefore they'll be open and they'll be ventilated and perfused. And you can see that in the picture. The vessels are wide open, the capillaries are wide open, allows for perfusion of the blood, therefore we have ventilation and we have diffusion of oxygen and so forth. So just know for this one, at zone 3 at rest, zone 3 is the base, everything is open, we're being perfused. In the apex, because of gravity, there's no perfusion in the apex, but they are still being ventilated. But there's no perfusion, therefore no gas exchange occurs in the apices. When you exercise, all these systems open up, the whole lung gets perfused, and you will have perfusion and ventilation in all parts of your lungs when they start to exercise. So let's talk about gas exchange. So in the very beginning, we talked about partial pressures of oxygen. At 0 feet, which is right about where we are, we talked about atmospheric pressure is 760. We know that 21% of the air is oxygen. So if you divide 21% of 760, you get 159. And then that's in the air. And then finally, when it gets into the lungs, we have 105 and then finally 100. Why do we have this drop? What is going on that we have this drop in O2 from the air into the lungs? Water vapor. We're adding in moisturizer. We're adding air or water into the air. We're moisturizing and humidifying the air so we can get into your lungs for better exchange. When you go very high, so Mount Everest, 30,000 feet, 19 is your partial pressure of oxygen. That's why they wear gas tanks when they go up. There's some people that refuse. They want to do it with no tanks, and they don't have any air supply. They just go up on their own. But again, you can see how by going in altitude, if you've ever even gone to like Denver, you may have problems breathing for the first few hours when you're there. We'll go through that, what happens with adaptation to altitude in a little bit as well. So we measure O2 dissolved in the blood plasma. When you do your pulse ox, it does not measure oxygen bound to hemoglobin in the red blood cells. We are just looking at free dissolved plasma of O2. And when the lungs are functioning properly, there's only a 5 millimeter mercury drop. And again, at about 100, hemoglobin is completely filled with O2. As long as that PO2 is at 100, you'll have sufficient loading of O2 into all the hemoglobin. They'll be all satisfied. In the blood, remember, we have to be set up in a way that allows for diffusion from high to low. So this is the lungs. Breathing into the air, we have 105 units of O2 and 40 of CO2. This is in the capillaries in the lungs. They get dissolved in. By the time it gets to the pulmonary vein, we're at 140. This travels around, goes to our arteries, and now we're in the tissues. At the tissue level, we have unloading of oxygen going into the cells, and we have CO2 being dumped into the blood. It's a waste product. We have to get rid of it. So we are adding CO2 and we're reducing O2 because we're extracting it. So when you look on the systemic veins, PO2 drops down to 40. We've taken 60% of the oxygen out of the blood. When it comes back to the right side of the heart, it's down to 40. We're adding CO2, so CO2 goes up to 46. Because all cell respiration, we produce CO2. It's going to build up. Obviously on the venous side, which takes all the waste products, CO2 rises, so that when we finally get back to the lungs, we have the appropriate setup where we have PO2 at 40, PCO2 at 46. So we have the right setup for diffusion. So that CO2 will leave the blood, go into the lungs, because only 40 in the lungs, it's 46 in the blood. So CO2 will diffuse into the lungs so we can exhale it out. O2 is only 40 coming back to the lungs. It's 100 in the alveoli. So O2 gets dumped into the blood because the diffusion gradient favors that direction. That's pretty much it on pressures of gas. As long as you understand that there has to be a diffusion gradient going in those directions. Understand we have to get rid of CO2, so CO2 has to diffuse into the lungs. We need O2, we have to get it into the bloodstream. So how do we get all this transport to occur? Hemoglobin is the molecule that does it. They're in the red blood cells. Majority of all the oxygen that we breathe in that gets diffused into the blood, majority of it gets bound to hemoglobin. Each hemoglobin can carry 4 molecules of O2. Obviously, we have millions of hemoglobin per red blood cell. So therefore, each red blood cell can carry millions of O2 molecules to the body, wherever it's got to go. Oxyhemoglobin saturation. So percent of oxyhemoglobin, what has been oxidized because it's bound to the hemoglobin versus your total hemoglobin. This is your pulse ox. How well the lungs have oxygenated the blood. A normal O2 sat, 97%. Okay, so 97% of our hemoglobin should be saturated with oxygen, and you get your pulse ox for that. Okay. Hemoglobin concentration. Obviously, if you have anemia, you have below normal hemoglobin levels, polycythemia, higher than normal. Erythropoietin is the one. We learned about that in the blood. When O2 levels drop in the blood, we're not breathing enough oxygen. We can't perfuse our lungs well. Diffusion is altered. Somehow we're anemic. We're not getting enough oxygen. Kidneys will sense it, and they'll kick out erythropoietin. Goes to your bone to start making more red blood cells. So we have more carrying capacity for oxygen. O2 levels go back to normal because we made all these cells. EPO production slows down because we're not anemic anymore. So that's what EPO does with the kidneys. We have to load oxygen, we have to get rid of it. So when we talk about loading of oxygen, loading always occurs in the lungs. Unloading is in the tissues. So we're going to learn how do we get oxygen and how do we unload it into the tissues and what kind of things will favor that to happen. So here's an oxyhemoglobin dissociation curve. We have on the y-axis percent oxygen saturation of hemoglobin. So we know 97% is normal. And on the bottom we have our PO2 in millimeters of mercury. So in our systemic arteries, it's about 100 and 100. We're close to it. So we're about 100% saturated at 97%, and we're good. Systemic veins, remember they're at 40 millimeters of mercury in the systemic veins as they're coming back to the lungs, back to the heart. That's at 40. So we're still at like 78%, 79, whatever, 80% saturated with hemoglobin, or oxygen saturated with hemoglobin. So again, like I was saying, only 22% of our oxygen is unloaded in the tissues. We still have 78% oxygen floating around in your blood. That's what I talked about yesterday with CPR. You don't have to breathe anymore. There's enough oxygen in the blood to last you the time while you're doing compressions. It's more getting the heart beating to provide oxygen to your tissues than getting oxygen in. You have oxygen still. You still have 78% of it. Okay, we're not losing all 100% of our oxygen in the blood every time we breathe. We still have a lot left. So what happens with different types of problems? So pH on oxygen affinity. What is affinity? What does that mean? Binding. If I have a high affinity for something, I like it, I want to be close to it. That's affinity. So pH will change the affinity for hemoglobin for oxygen. If the affinity for O2 decreases, less binding to it, with a low pH, it shifts it to the right, down and to the right. If the affinity for O2 increases, like at higher pHs, it shifts to the left, up here. So you can hold on to more O2 during periods when our blood is alkaline. When our blood is acidic, we don't hold on to O2 as much, we can get rid of it faster. And this is just called the Bohr effect when this happens. This is the effect of pH on affinity for hemoglobin. So you can see here, when affinity is normal, our O2 count is about 19.8, but look at how much O2 is unloaded at the tissues, 5. When you have a decreased affinity, pH goes down. We unload more oxygen, 6.6 milliliters. So just don't worry just know the values go up. Yes?
What is the y-axis?
On this one?
Yeah.
Oh, it's just that hemoglobin dissociation curve, like percent oxygen.
Oh.
Let's put. It's in different ranges. This is 1. So you can redraw it as 100, 50, and we know that, there's that 80%. Okay, temperature. As your temperature, the affinity for O2 is decreased at increased temperatures. It's going to shift it to the right. What's an example of when your body is going to heat up naturally and normally in a normal physiologic process? Exercise, right? When you start exercising, your body gets hot, you start sweating, get overheated. When you're exercising, the temperature goes up, it promotes unloading of O2 to your tissues. Does that make sense? We're exercising. We need more demand of oxygen in our tissues. When their temperature goes up, it favors unloading of oxygen to the tissues where they need it. The blood doesn't need oxygen, the tissues do. So when you increase the temperature, you favor unloading of O2 so it can go to the tissues where it's needed for demand. Affinity for O2 is increased with decreased temperatures. As you get colder and colder and colder, your hemoglobin is going to stick and bind to that hemoglobin tighter when your temperatures are colder. So that's temperature on the effect. And we'll skip that one. Let's see where we're at here. Okay, we'll finish this part and we're done. Okay, you have the real one. It's just everything I already talked about on that part. Carbon dioxide transport. Carbon dioxide is in 3 forms and how it can get around in our bloodstream. 5% will be dissolved in plasma. Remember, it's a gas that can dissolve in the liquid, so it'll go right in. 5% will be bound to hemoglobin. It's called carbaminohemoglobin. The majority of it, 90%, will get converted into bicarb through the use of chloride. And we'll talk about that in a minute. So 90%, the CO2 gets converted into bicarb, and we'll see what happens as we go through the body, what that bicarb does. So we use this thing called the chloride shift. One bicarb ion is formed in the red blood cell. It diffuses into the plasma. So there is our bicarb right there in green. It comes out, but a chloride ion will come in as an exchanger. They're both negative. Chloride is negative, bicarb is negative as well, HCO3 minus. They're both negative. They just help each other out on the way out. So we have our CO2. Goes into the blood plasma. Some of it will stay in the blood, but remember, some of it will also bind to hemoglobin. That's that second type. 5% will stay there, 5% stay there. But the majority of the CO2 will combine with water to form carbonic acid. This carbonic acid also undergoes a bidirectional event with enzymes to give you bicarb plus an hydrogen. And this bicarb here is what diffuses out in that chloride shift. So where is this happening? In the tissue or in the lungs? This is happening in the tissue. So the chloride shift occurs at the tissues. Okay? Chloride shift occurs in the tissues. When we get to the lungs, the opposite happens, and it's called the reverse chloride shift to get it back to CO2 so you can exhale it. We'll talk about that in a second. These double arrows are under the influence of an enzyme called carbonic anhydrase. Carbonic anhydrase, it's an enzyme. It allows the conversion of this to happen. So CO2 with H2O makes carbonic acid. The carbonic acid then dissociates to make bicarb and a hydrogen ion. That hydrogen ion in the red blood cells attracts the chloride to want to come in to the cell. H is positive, chloride is negative, they're going to attract. So it helps bring that chloride into the cell. So this is at the tissues. Now we're at the lungs. Okay, we have to get rid of it. Okay, so this is the Bohr effect, talking about binding the hydrogen to the hemoglobin, which is made in this process right here, or back out. Again, helps carry more carbon dioxide. And this is what happens. Here's the reverse. Okay, here we are. Here's the reverse chloride shift. We have to get that bicarb back to carbon dioxide, because we can't exhale bicarb. So we repeat the process. We do it the opposite way now. So the chloride shift, the bicarb in the lungs will go into the lung or into the red blood cell. Chloride will leave the red blood cell. Let me erase that. Chloride leaves the red blood cell. It's called the reverse chloride shift, and everything happens in reverse. So we get bicarb coming in. It's going to bind with the hydrogen again, causing carbonic H2CO3 carbonic acid to form. Then undergoes again with carbonic anhydrase to make CO2 and water. The CO2 you just exhale. So chloride shift is in the tissues. The reverse chloride shift happens in the lungs, so you can get rid of CO2, yes?
The anhydrase also enters the RBC?
It's always in the RBC, it's only where it is. So this whole reaction occurs within the red blood cell. That's where carbonic anhydrase is located, in the red blood cell. So if you understand the formula up here, the long way to write it, I'll just do the whole thing again. So it's all one line. You can do one way is CO2 plus H2O. Where does this equation occur? Tissue or the lungs? Then in the lungs, we have to do the reverse chloride shift. So we get HCO3 minus plus the hydrogen, carbonic acid, and that's in the lungs. Just the same formula front and backs. One's in the tissue, one's in the lungs. We have to get rid of CO2. We can't let CO2 float in our blood by itself. What's going to happen? Well, if we remember, only 5% is actually dissolved in the plasma. If more was dissolved in the plasma, what happens to our pH? It's going to drop. We have a lot of CO2 floating around, so we have to get rid of the CO2. We can't just let it be there. So by putting it into the red blood cell, converting it into bicarb, we're able to reduce the acidity of the blood, so we don't get acidic all the time. Chloride shift in the tissues, reverse chloride shift in the lungs, so we can exhale the CO2 and get rid of it. So reverse chloride shift at the alveolus, carbonic anhydrase, the enzyme converts carbonic acid back into CO2 and water, and we exhale the CO2. And that's how we can move chloride. The chloride shift occurs due to CO2 regulation. And we'll do acid-base tomorrow. Any questions? see me. Otherwise, I'll see you guys tomorrow. Work on those. If you have any questions with the exam master, let me know.